you and I are going to see much more commonly is posterior instability, where the humeral head moves backwards from its relationship to the glenoid. This usually happens from flexion and internal rotation. Swimmers, linemen, overhead laborers, and you and I and everyone else in the world sitting at a workstation for prolonged periods of time. We just make that capsule a little less stable. Usually this is not traumatic. It's repetitive activity in the same plane. And it usually causes discomfort or a loss of function, especially in the mid-range. So a lot of our throwers will have some issue with some posterior instability. It's not as dramatic. It's not one of those shoulders that the patient says, oh, it's clunking and it's really uncomfortable and I can't do this. It's usually a little bit more subtle and can look much like the rotator cuff, hence its reason for being here today. So the biggest thing that we want to know is how do we assess it and how do we stabilize it? Because we can stabilize those shoulders. We can teach the patient a series of exercises that make a big difference and will now allow our treatment to really make a bigger difference in their life. The first thing that we can do is the posterior apprehension test. All of these tests, as you might imagine, are simply taking the humeral head and shearing it posteriorly. Can we reproduce the patient's chief complaint or a sense of instability by creating some discomfort? So posterior shearing is going to take place by stabilizing the patient's trapezius and scapula and applying an axial compressive force through their humerus to shear that humeral head backwards a little bit. If they say, that doesn't feel so good, that's a sign of posterior instability. We can also do a posterior drawer test. Much like the drawer test of the knee, we're going to shear it anterior and posterior. The posterior drawer test, not surprisingly, is just grasping the humeral head and shearing it backwards. And we're probably going to shear it back and a little bit laterally as well. Remember that humeral head is going to kind of follow the angle of the thorax. And if we shear it a little bit anteromedial and a little posterolateral, that would be the angle of the thorax. If the patient reports some instability or discomfort, or you feel the humeral head move more than about half of the width of the glenoid, that's a sign of instability. All of these we want to compare side to side. How's it feel on the right side versus the left side? A couple other tests that we'll do. Number one, the load and shift test. The load and shift test, as it sounds, we're going to shear that back. And this is where we're going to take it in that plane from anteromedial to posterolateral. So we have to stabilize the trapezius, the clavicle, and the scapula as best we can with our upper hand while we're using our lower hand to shear posterolateral and anteromedial. And here's where we really don't want to see that moving more than about half of a glenoid width. The last test that we'll do is the push-pull test, or at least the last assessment for instability, the push-pull test. And for this one, we're going to push on the glenohumeral capsule while we pull on the arm. So we take the patient's arm into a state of 90-90, and Dr. Steele is going to pull up on Christy's forearm as he pushes down on her capsule. Once again, just trying to shear that backwards. So we've sheared it in a number of planes to see where is that instability.
So one of the things to note is that we don't do all these tests on every patient. It's very similar to the other tests going into Hawkins-Kennedy and Neer's test, and then if we see some positive shoulder pain, then we go into empty can test. The same thing is going to happen with this, is if a patient is unable to go into external rotation for the apprehension test, that's going to lead you along that pathway of going into instability tests. Loss of external rotation, labral problems, adhesive capsulitis, or these types of issues. So I'm not going to dive into joint relocation surprise release test unless I get that positive test and they're showing the signs and symptoms. We're not going to do these tests on every single person. It's also always good to have them gravity bound at the very beginning. That's why you see the patient seated for those, because they're going to use the muscles they usually use to do that motion. And then if you want to actually get into and see where that directional instability is, that's when we're going to lay them down supine and get all those postural muscles to relax before we do that assessment.
And much like spinal instability, once we have a factor that indicates there's probably some instability, we probably don't need to reinforce that with 4 or 5 more tests. If there's instability, there's a need for some stability. I've never seen a shoulder that's too stable, maybe outside of adhesive capsulitis, but most shoulders are going to be inherently unstable, especially if they've been used in that repetitive motion. And most of the ones that you and I will see are going to be this variety of the posterior instability. Last test to assess the muscles, because remember, not only do we have the static stabilizers of the joint and the ligaments, which we just tested, we also want to see how do the rotator cuff muscles function. Those 3 big muscle groups are the big movers, which abduct your arm. There are the rotator cuff, which tend to depress and retract the humeral head, and then the scapular movers and stabilizers, which rock the scapula. This dynamic rotary stability test tests how well the rotator cuff holds that humeral head in place simply by having the patient try to make a pitching movement from mid-range. If there's no discomfort or instability, cock back a little bit earlier in the throwing phase and have them do it again. And see, is there some discomfort? Do they say, ouch? And we'll see a lot of our pitchers and overhead athletes where this will be positive. So when that's positive, what are we going to do? Well, we're going to teach that patient how to make their shoulder more stable. Certainly we'll get rid of any cervical components that are there, any rotator cuff components that are there, because many times these are concurrent conditions where there's some neck, there's some rotator cuff, and there's some instability. And unless we get rid of all three of them, we're not going to be able to resolve that problem. The first exercise that we can do for a patient with posterior instability is the modified belly press. You remember the belly press test? It's one of the really good tests for determining is the biceps intact and functional. It's also a good test to say how well does the rotator cuff stabilize. So we turn it into an exercise by having the patient lie on their back, put one hand on a pillow, and simply press down on that pillow for a few seconds, relax, and press down on the pillow. Very little stress to the shoulder, but a good way to help start strengthening those muscles. Then we can incorporate the Derby program, one of Dr. Steele's favorite programs, the Derby exercises. That there's a whole bunch of them. There's Derby 1A through E, and then there's a 2 series as well. So we'll start that patient with the 1 series. One thing to remember is that when it comes to posterior shoulder instability, we can probably create a relatively consistent protocol for that patient because it's a similar mechanism of onset typically, and they're at a similar state of pathology. When it comes to treating anterior instability, there is no protocol. In fact, a recent study said that 80% of therapists who treat that do not use any protocol for an anterior instability because there are so many factors. Is it acute to where the patient should just be doing some light mobility? Is it something they can start some isometrics? Can they move into more dynamic exercises? It depends on so many factors that it's really a one-off. So we've not created a protocol for anterior instability. It would probably be a disservice to the patient and to the providers. For posterior instability, it's a little bit more predictable. So this protocol starts with the modified belly press, and then we move into Derby 1A. And Derby 1A is simple exercise, having that patient take their arm out and then drop a weight and re-catch it before it hits the floor. So Christy brings the weight up to about shoulder level, a couple of degrees above, and drops that light weight just a couple of inches and then re-catches it. So an eccentric loading of that muscle to help promote some stability. The next one that we would move into is a Derby 1B. Real similar, but this time with her arm at 90-90. So she'll take it up, bend her elbow to 90 degrees, and once again just drop that weight and re-catch it before it hits the floor. And an exercise that's usually not overly challenging for the patient. If they do have some degree of impingement concurrent with this, then we can have them bring their arm down just a little bit so that we're not putting it up into that impingement state. And then the third one is the Derby 1C. This is with them lying on their back, and again they're going to move into a 90-90 position. And this one's a little bit more awkward. They're going to take their arm back and move it away from the weight and then re-catch it. So she's going to abruptly move her arm into external rotation and let the weight follow her down a couple of inches. So sometimes it doesn't leave the palm, but sometimes the patient can move quickly and get their hand away from it for just a second. And then the final one that we would use for our protocol is the 1D, and this is simply having the patient stand close to a wall and fall into the wall and catch themselves. As they become better at this, we move them away from the wall and then eventually onto a very stable table that they can fall down and catch themselves on a table. So you can see that she stands up and she's going to fall into the wall and catch herself with her shoulders at about, with her hands at about shoulder width. That we don't want it too wide, especially if there's multi-directional or anterior instability. That patient won't like that. You're reproducing the apprehension test. But we're getting them ready to tolerate apprehension a little better with their hands close. The one thing that we want to remember is when you hit the wall, push yourself back up. So rather than using your body to stand yourself back up, actually use those muscles to push back off again.